All right, I want to welcome everyone tonight. My name is Jeffrey Sagel. I'm the Assistant Medical Director for Baltimore County Fire Department and the Medical Director for the Baltimore County Volunteer Firemen's Association. Uh, Additionally, I serve as the Chief of Anesthesia for Sinai Hospital of Baltimore. I am by training cardiothoracic anesthesiologist. Additionally, I've done a few other little residencies just to keep me up to date. I have a faculty appointment at the Uniformed Services University School of Medicine in Bethesda, and I am also the medical director for the United States Park Police. I want to welcome everyone tonight to our talk. This is respiratory therapy for the pre-hospital care provider, from nasal cannula to intubations, and actually a little bit beyond. I've given this lecture a few times, or something similar to it. It's been altered and changed to meet the needs for this course and program, but it started out as a White House Medical Unit lecture. And then we've taken it from there. Wait a second. This would be Eagle One flying over the White House, which is pretty cool. That's my other ambulance. I'm still living the dream, as they say. But I want to talk about respiratory therapy, respiratory distress, breathing in general. The normal, when you breathe air, you will breathe an FiO2 of 20.8%, or because anesthesiologists like even numbers, an FiO2 of 20. And that's normal. And then the other 80% of what you breathe is nitrogen and various minute gases and pollutants. And that's great. But your brain, which is very highly metabolic, requires oxygen to live. So does your heart and every organ within your body, and it has a very effective system for delivering it through the lungs. The fascinating part about it is, however, is if you turn off the spigot, after 4 minutes, you run out. Your alveoli, when you're breathing room air, make up a certain reservoir, and it will pull through diffusion. There's no active transport across the alveoli, and deliver it to the brain and all your organs through this highly efficient system controlled by your heart and brain itself. But if you stop the delivery, just whether you're underwater or you stop breathing, after 4 minutes, you run out of oxygen. From the next 4 to 6 minutes, cells are in a bit of a struggle, especially those that have high metabolic requirements, such as the brain. And then at 6 minutes, they are now starved, and they might develop a little bit of apoptosis or cellular death, and they start swelling so that by 10 minutes, they're dead. That's it. You are 10 minutes from death. So all the emergency airway algorithms, they start with A, B, C, D, and go their happy little directions. In my realm, anesthesia, we have the monopoly on airway and breathing, as does RT, the respiratory therapists, and the paramedics and EMTs, everybody in the ambulance. You need to have airway and breathing before anything else. And we're going to talk about that today as I learn this. All right. So when you're in respiratory distress, we can talk about airway adjutants, and we have some non-invasive airway adjutants. The very first is the most simple. It's a nasal cannula. It will give you supplemental oxygen. It's designed to flow at a rate of 1 to 6 liters per minute. It will raise your FiO2 by 4% per liter flow. And that's a common test question in EMT and beyond. Nasal cannulas are very well tolerated. At 6 liters, you will raise the FiO2 from 20.8 to 44%. Now, the interesting thing about nasal cannulas is once you hit over 6 liters, they don't work so well. Based on the diameter of the tubing and protective devices, over that, you get a laminar flow of the oxygen in the hose to a turbulent flow, which increases resistance, so no flow. Above nasal cannulas, we have face masks. They can supplement oxygen also. They're also non-invasive. You have a simple face mask, which has a design to flow from 6 to 10 liters, which can give you an FiO2 of 44 to 60%, versus a non-rebreather face mask, which has a 1 liter reservoir bag that fills. So they have to flow at least 10 liters and can go as high as 15 liters. And that will send your FiO2 from 60 to 80%, depending on it. The trouble with face masks is they're not as well tolerated. People don't like to wear them. They don't like it scratching on their face. They don't like it feeling on their nose. And for some reason, a lot of people feel that they're oxygen starved, even though it's not the mask and the mask is making the delivery, but it's the bigger picture. Above the face mask, we enter the realm of CPAP masks. These are also will supplement oxygen. If you're a Maryland medic, the protocols say they have to be at least 13 years of age to go on it. These are designed to start at a 15-liter flow rate, and they can give you an FiO2 of 100%. When do we use them? Patients with respiratory distress from pulmonary edema, COPD, asthma. But these patients need to spontaneously ventilate. They have to be able to maintain their own airway. And then you can do a CPAP mask. CPAP mask can buy time, but that's okay. Do not use a CPAP mask if the patient is vomiting, because the masks are held tight to the face, and then you run the risk of trapping the emesis and then them aspirating it. Once we've exhausted our non-invasive airway adjutants, we start getting to the realm of more invasive airway adjutants, such as oral airways and nasal airways. How do you know which one to use? It's simple. If they have a gag reflex, a nasal airway. An oral airway can't be used because it'll cause them to vomit. Whereas if they don't have a gag reflex, you can use the oral airway, and then that'll be fine. A few other things to remember for these things is that if they have no gag reflex, you can use an oral airway, and you can actually bag ventilate it to somebody with an ambo bag. For nasal airway, again, for the patients who have gag reflexes, you have to remember they're fine if they have a gag reflex, but you can't stick a nasal airway in a patient who's had a head injury or anybody who's on any blood thinners or anticoagulants, because they will bleed, and they will bleed a lot. Trauma patients, you run the risk of fracturing the cribriform plate with it, then the airway enters the dural sinuses, and then they'll bleed to death. No trauma, no anticoagulants. These are designed to get around the #1 cause of airway obstruction, which everyone knows is the tongue. For a little history, we had esophageal obturator airways and combi tubes, and I'll just say be glad they're gone. But we'll say back in the 80s, these were the things, because EMTs could do these as blind intubations. You'll notice on the picture, the EOA was designed that after you put the tube down, you push the mask to the face, and then you blew in the mask. Thank goodness that's over. And then the combi tubes, you stuck it in, and then you had to figure out which was in the lung and which part was in the esophagus. And then you could ventilate with an ambo bag through the proper one. They're both gone. Good riddance. Next up would be extraglottic airways. The original one was called a laryngeal mask airway, or LMA. These are indicated to oxygenate and ventilate patients with compromised airways, airway obstruction from the tongue, and they don't have a gag reflex. You can't put this in somebody with a gag reflex. It can also be used for patients who are in the process of rapid sequence intubation that have failed intubation attempts as a bridge, and we'll talk about that later. Other extraglottic airways are the King airway, the AirQ, iGels, in addition to the traditional LMAs. But what do we do when airway adjuvants fail? Nasal cannulas, oxygen masks, CPAP masks, oral airways, nasal airways, the LMAs. What do we do? Well, what is respiratory failure? Respiratory failure is the marked impairment in ventilation and perfusion matching. It's an impaired ventilatory drive. It could be weakness or fatigue of the muscles associated with it. It can be a hemodynamic abnormality. There's 2 types of respiratory failure, and they're independent of each other. Most of the time you will have both, but you can have one or the other separately, independently. You're just going to have to accept that. It's very deep, the proof, and it's above the realm of this course. So the failure to deliver oxygen, that's hypoxic respiratory failure, versus the failure to eliminate carbon dioxide, that's a ventilatory failure. One, the other, or both. All right, so you're not breathing. We have impending respiratory failure versus respiratory failure. Soon to be not breathing versus not breathing. What's the difference between the two? Soon, or time. Time is the difference. It's better to secure the airway in a patient with impending respiratory failure restore cellular oxygenation and ventilation to the brain, to the heart. That way you do not have to deal with the consequences of respiratory failure that's associated with cardiac arrest. They start out with arrhythmias, or CNS risk, which is cerebral edema, brain swelling, followed by herniation and death. You don't want to deal with that. So how do we know where we're at? Well, we have physical signs and symptoms, and there's lots of them. They're variable. Rarely will any patient have all of them, but any of these can be present. Some of them are pretty big, and some of them are rather insidious. But if you put the big picture together, you can add it all up and decide what's going on. So what are these symptoms? Well, cyanosis. They're pale, they look blue. Well, how do you tell if someone's cyanosis if their skin is dark? I mean, I look at people's lips when I decide if somebody's cyanotic or not. Lips are always pink. I don't care what a person's race or ethnicity is. Their lips are pink unless they're wearing lipstick, in which case, if they're coming to the hospital, the operating room, which for some reason people like to put lipstick on because they want to look good for me, I don't know. But as soon as they're asleep, we wipe it off. We look at their lips. You can also look at fingernail beds or look at the patient as a whole. Just memorize them. Nobody should look like a Smurf. Tachypnea, respiratory rate greater than, depending on who you read, 26, 28, 30. Apnea, not breathing. Stridor. Stridor is upper airway obstructions, high-pitched whistles, versus wheezes, which is lower airway obstructions in the bronchial tree. Again, high-pitched whistles, just from deeper within the chest. Rales and rhonchi. Commonly confused with each other, a lot of times used wrong. They have their own definitions. And sometimes you can have both. What is a rale? Rale is heart failure. It's always bilateral. It always starts at the basis for someone sitting up, and it always works its way up the chest. If they're lying flat, it's at the back and it works its way to the top of the chest. Rales, bubbling in the chest, bilateral always, versus rhonchi. Rhonchi is a pneumotic process or infection. Infections can be anywhere in the lung. There's 5 lobes: upper lobe, middle lobe, lower lobe. It can be on both sides. It can be in more than one lobe, hence my favorite term, bilateral pneumonia. You have it twice. I don't know. I have double pneumonia. Yeah, whatever. Again, they sound the same, but rales are anywhere. And a lot of people with heart failure can have chronic infections. So it's either. So rales and rhonchi. Shallow respirations, mental status changes. Mental status changes. What causes mental status changes? Elevated carbon dioxide. You start getting confused. Or hypoxia, not enough oxygen reaching the brain. Agonal respirations, respiratory rate less than 6. Pursed lips. You see that in very old people and very young. They close their lips to exhale, and that creates positive end expiratory pressure, which allows oxygen to stay within the alveoli just a little bit longer. Anybody with upper airway burns. Frothy sputum, lots of causes, usually heart failure. Tachycardia. Tachycardia is always early warning for something. Heart rate greater than 100, and very rare is it good. Somnolence, they're sleepy. They shouldn't be sleepy, but they are. Usually, high CO2 can be hypoxia. Tripod posture. And you see that especially in little kids. They lean forward, their chin is up. What they're trying to do is straighten out their airway and change a laminar or create a laminar flow from a turbulent flow. So they want to extend their chin and they rock as they breathe. Nasal flaring, babies. Babies are obligate nasal breathers. They breathe through their nose most of the time because they have such large tongues. Glasgow chroma scale less than 8. Again, problems. Unconscious, well, that's an easy one. Anybody with pulmonary edema, anyone who's diaphoretic, sweating, grunting noises, intercostal retractions, you should not see the muscles of the ribs to help you breathe working. Angioedema, what is angioedema? Angioedema is different than peripheral edema. Angioedema usually occurs all over the body, generally associated with allergic reactions. The most common ones, lisinopril, but it can be with anything that's an allergic reaction. Pit and edema usually start in the feet and it works its way up. Pit and edema, if you push into it, you get a divot. Angioedema, very tight. Angioedema is a true medical emergency. Angioedema leads to lots of trachs in the emergency department or the operating room. Decreased breath sounds for whatever reason. Cardiac arrest. Well, that's an obvious one. Dyspnea, paradoxal respirations. Paradoxal respirations are from spinal cord injuries. Accessory muscles of respiration in the neck. You should not be seeing them. These are all physical signs and symptoms, but we like numbers. So let's talk a few more numbers. From the MIMS protocol, inadequate respiratory rate is an adult rate less than 8. Adolescents, which is 13 to 18 years of age, a rate less than 12. Child, 1 to 12 years, less than 16. Infants or toddlers, less than 20 breaths per minute. We kind of talked about some physical signs. Heart rate, adults or adolescents less than 60 unless you're a well-conditioned athlete. Children between 1 and 12, less than 80. Infants, less than 100. These are all numbers associated with respiratory distress or respiratory failure. All these patients need to be oxygenated and ventilated. That said, if you don't want to depend on your physical and you can do one thing and one thing only, what would it be? Pulse ox. We like pulse oxes. It's the principle of oximetry and plasmaphotography to non-invasively measure oxygen saturation within your arterial blood using a light sensor. It shines a red light at 2 waves, 660 and 940 nanometers, and it looks at absorption differences, and it will calculate it. Pulse oxes run a math formula, so they need a little bit of time to work. But they measure the difference of oxy versus deoxyhemoglobin within the blood in pulsatile vessels. And then it will take this information, this absorption, and it will calculate the saturation. And it makes the assumption, I had laryngitis a week ago, so I'm actually doing pretty good. But it will make the assumption that with a higher saturation, oxygen delivery is good. Lower saturation, not as good. We'll talk about that a little more. Now, for the paramedics, remember about blood gases. The PaO2, the partial pressure of oxygen within your bloodstream. If your saturation is 90 to 100, it's associated with a PaO2 over 60, and that's normal. If the saturation is between 80 and 90, it's associated with a PaO2 between 50 and 60. Not so normal. If your sat's between 70 and 80, it's associated with a PaO2 between 40 and 50. Now, what's interesting is, and I see it a lot, that people will come to the emergency room and they'll say, oh, they're doing bad. Their SAT's 45. It's not really true. Pulse oxes generally don't work below 70. You can get numbers, but I can tell you this, once your PaO2 reaches between 32 33, sometimes 34, the red cells are not going to let go of the oxygen. They're going to keep it for themselves because they don't want to die. So they're not going to deliver it. But I can tell you if the SAT's less than 70, it sucks to be them. That's a problem. So SATs of 50, 40, nothing. It's less than 70. That's a problem. They're in respiratory failure. So pulse oxes can be affected by things. Heart rate. Remember, it's a computer program running continuously to give you these numbers. Heart rate, depending on the model, greater than 140, greater than 160, they don't work too well. Heart rate's less than 50, 40, they don't work. That will fool a pulse ox. Carboxyhemoglobin, carbon monoxide poisoning. Carbon monoxide binds to red cells 32 times greater than oxygen. So, and it will displace the oxygen, yet your pulse ox will read 100%. Of course, what's our clue for patients who have carboxyhemoglobin? Well, if they weren't in the fire, you look at them and the carbon monoxide alarm's not going off, they have cherry red skin. Methemoglobin, what's methemoglobin? In EMS, we see methemoglobin associated a lot of times with nitrics or nitroglycerin. And it causes a configurational change in the red cells so that they can't absorb as well. They're still carrying the oxygen, but your pulse ox is going to be low numbers, yet they seem to be okay. If we draw blood on it, you notice the blood looks a little bit like chocolate. Interestingly, we can fix methemoglobin in less than 2 minutes with a drug called methylene blue. Ambient light, fluorescent light bulbs will play with the pulse oxes. I honestly don't know about LEDs. I haven't seen them enough yet in the OR to realize that that's going to interfere. Artificial fingernails, the light can't shine through it, those gel nails. Nail polish, especially red, blue, black, kind of fools the pulse ox. Patient has artificial nails or nail polish on, turn the pulse ox sideways. Go through the sides of the fingers. You don't have to go through the nail beds. Of which, where can you put a pulse ox? If not the fingers, you can stick it on the nose, you can stick it on the lip, fingers and toes. They make certain types of pads that you can literally put it right across the forehead and it'll work just as well. Anemia, low blood. You need boxcars to deliver the oxygen. Not a lot of blood, not a lot of oxygen delivery. That will fool the pulse ox. If they're cold, remember when you're cold, you vasoconstrict, so your periphery will clamp down. That fools the pulse ox. So the bottom line is this. If your SAT's greater than 90, life's good. If it's between 80 and 90, you have a little bit of time. If it's less than 80, you have impending respiratory failure and you need to act. So what do you do if your pulse ox is between 80 and 90? Well, this is a good time for your adjuncts. Stick a non-rebreather mask on or a CPAP mask on. If the SAT's between 80 and 90, say it says 92, you stick a non-rebreather mask on and it goes to 94. From 82 to 94, life's good. Same with the CPAP mask. If it goes from 82 to 84, not so good. Stick with the CPAP mask if you can't do intubation or invasive airways because the patient's still conscious, and get to the emergency room because they're going to tire out and run out of gas. So the conclusion on this is the physical signs and symptoms identified on your physical exam and with pulse oximetry should allow one to determine if a patient needs to be intubated. I get calls to the wards of the emergency room lots of times. We just want to give you early warning. We think the patient needs to be intubated. We sent off a blood gas. We're waiting the results, but we want you ready just in case. I look at the patient. I look at the SAT. And then I decide then and there they need to be intubated or not. And I've never in over 30 years been wrong. Physical exam, pulse ox, you can make the decision. I don't need a blood gas to tell me. Neither do you. So what do we need to remember? There's no contraindication to a patent airway. I don't know how many times we have to say that, but it's true. That said, you can't get any more patent than an endotracheal tube. It's the gold standard. As I say, never accept copper if you can have gold. Like the little trivia question for the people out there to the right, at least on my screen, there's a gold coin. What is it? Any ideas? I don't know if I should wait for the remarks. I can't see them. I can't see the chat. So I guess I'll just give it up. Remember, I used to work, I gave this lecture down in DC for some people. It's a US gold $10 coin, 1989 US Capitol. So you got to put in a commercial plug for the government when they're paying you. All right. So let's talk about RSI. This picture came off of Medic 17 a while ago. I suspect a few of you know who that is. Thank you for being in my picture. So we need equipment, basic equipment. We need an EKG. Baltimore County carries LifePak 15s. We need a pulse ox, continuous pulse ox. We need a blood pressure monitor. You need a positive pressure oxygen delivery system, such as a Mapleson C, classically called the AMBO bag, and you need an oxygen source, whether it's tank or central supply. That said, in a worst case scenario, when people aren't breathing, nobody will complain if you bag them with room air because something's better than nothing. Of which, to remind you, when people stop breathing, 4 breaths will restart the clock. You need suction. I've learned a long time ago, everyone stops at Burger King or McDonald's before they get shot, have their heart attack, go into heart failure, have those nice salty French fries. You need suction. Large capacity suction, large volume suction. And then we need laryngoscopes. Laryngoscopes come with a handle and a blade. There's 2 types of blade, curved or Mac blades, and straight blades, which are Miller. Blade sizes are 1 through 4. for Mac and 0.4 for Miller. You need handles. They make adult handles. They make pediatric handles. They also make what's called a short stub handle for morbidly obese people. I recommend the fiber optic blades over light bulbs for your light source. I can tell you in Baltimore County, we're in the transition. Some units have light bulbs, some units have fiber optic. The problem with the light bulbs is in a moving ambulance, it can loosen pretty easy, and there's nothing more embarrassing than having your bulb fall off into the posterior pharynx of the patient. Always have an extra set of batteries. What? Being stared at. All right. Again, a laryngoscope, classic laryngoscope with its parts. The one on the left is a Miller blade. It's straight. The one on the right is the Mac blade. The one on the right is a fiber optic, no bulb to fall. And the one on the left has the bulb. What's the difference between these two blades? Well, what are they designed to do? A Mac blade, or the curved blade, is designed to go over the tongue and into the vallecula, which is a space, and I'll show you a picture in a little while, above the epiglottis. Lift up, pull the epiglottis with you, and visualize vocal cords. Whereas the Miller blade is designed to grab the epiglottis, and then you still see your vocal cords. And unless you can see around corners, if you can see it, you can hit it because that's a straight shot. You look to the right of the blades, you see these little channels. Now, the classic mistake made for people who go to intubation is they try and stick it down the channel, and it will get caught, especially in Miller blades, in the channel. Don't do that. The channel's for your eyes to view. You're going to want to come in from the side. All right. And then we have video laryngoscopes. They've been out for more than 10 years at this point, the first one being a GlideScope Ranger. And they have revolutionized airway management. I participated in a trial with a video laryngoscope with the military, and we were taking patients. I had a paramedic with myself, and we were going from room to room just playing with it. And unfortunately, we got called to an operating room where the patient was going to have, they couldn't get him intubated and they couldn't ventilate him. So it was a true airway emergency. He was medically paralyzed, wasn't bleeding. We went in there, they were prepping the neck for a trach. I told the paramedic, intubate him. He looked at me and I'm like, he's getting a trach, who cares? Stick the tube in if you can. And within 15 seconds, the patient was intubated. When somebody who'd only done 5 tubes at this point with a video laryngoscope. He was a good paramedic and very good with laryngoscope, but this patient, which was a very difficult intubation, did not get a trach and got intubated. And it definitely made it well for the makers of GlideScope because they got approved. So video laryngoscopes, this is a GlideScope Ranger. They're still out there. Popular with the military. This is a GlideScope Go. I can tell you this is what we use at Sinai Hospital. You have the King Vision, you have the CMAC, and you have the McGrath. And these are all designed to give a view of the larynx. And it's basically revolutionized laryngoscopy. My guess is within the next 5 years, laryngoscopes are going to basically disappear and be replaced with these. They've taken airways that were previously difficult and made them rather simple. It's easy to use and it's simple to teach. We'll talk about it more a little later. Other equipment. You need a McGill's forceps. McGill's forceps are designed to retrieve foreign bodies. Lots of people choke, lots of people aspirate. I've pulled out food, dentures, coins. Recently, I pulled out a lychee seed out of a larynx of a choking child. Again, these are designed to retrieve foreign bodies. They can also be used to aid in intubation. If you can't quite make it with the tube, you can reach down, pull it up, and guide it into the larynx. But they basically reach into the back of the throat. You need ET tubes. There's 2 types of ET tubes. Uncuffed tubes, which come in sizes 2.5 to 5.5 versus cuffed tubes, which start at 4s to 9. What do the sizes mean? This is the internal diameter of the tube. That's what it refers to. Again, looking at the side by side, the tube above is a cuffed tube. The tube below is an uncuffed tube. How do you know how deep to stick the tube in? Once the cuff is in, you stop. There's no extra credit for going 1, 2, 3 centimeters deep, none whatsoever. The uncuffed tube, there's usually a line on it, and you can see it on this one here. You stop at the line. That's it. You're in. Cuff tubes, the cuff is designed to be low pressure, high volume tubes. Everyone uses a 10 cc syringe attached to it, which is fine, but these cuffs are supposed to have enough pressure that the pilot balloon, which is the blue one above, is blottable or you can squeeze it, versus the cuff itself. If the cuff is tight in the trachea, it won't come out. The trouble is the trachea is pseudostratified ciliated columnar epithelium with goblet cells. And yeah, I did that in one breath. Somebody's staring at me. And it is sealed, or it is perfused by a capillary bed, which has a blood pressure of about 30 millimeters of mercury. If the pressure in that cuff is greater than 30 millimeters of mercury, then you'll get ischemia and an eventual breakdown within the capillary bed and then the larynx, and it's not going to heal, and you're going to get what's called tracheal stenosis, which is a horrible thing to do to somebody. So the blue pilot balloon should be what's called blottable or easily compressible, and that transfers to the cuff. When people are intubated in the field, first thing we do when they arrive at the hospital is we check to make sure the tube's in the right hole, and we look for end-tidal CO2, and then we measure the pressure in the cuff to make sure it's not too high. At the end of the AT tube, you'll notice there's something called a Murphy's eye that is designed in case the tube is pushing onto something to breathe around it so that you can still ventilate. The connector, doesn't matter what size the tube is, the connectors are universal. They're standard, whether it's a 2.5 tube or a 9.0 tube, it's the exact same size, and they will fit any manufactured ambo bag in the United States. It's a standard for all manufacturers must follow. So again, tubes are sized based on their internal diameters, and they increase in size by 0.5 millimeters, from 2.5 to 9. How do we know what size tube to use? Well, for pediatric patients, you can use the formula age plus 16 divided by 4 for the purist. So somebody who's just born, they start out with a 408T tube. Or you can look at their nares, the internal nares. The body's likes laminar flow, so your nose opening is actually going to be pretty much the same size as your vocal cords. Now, on kids, remember the narrowest part of the pediatric trachea is the cricoid ring, not the larynx, but that changes roughly close to 6 to 8 years of age. Or you can look at the tip of their fifth finger. I just look at their nose, and that works for adults too. Again, uncuffed tubes are used in neonates, infants, and toddlers. The transition occurs around 8 years of age, at which point they're a 6.0 tube. But you can use cuff tubes in them versus adults. Uncuffed tubes, again, the narrowest part's the cricoid ring versus a cuff tube. A cuff tube will protect you from aspiration. Again, little kids. So you have a 6-year-old, you're afraid they're going to aspirate. You can use a half size smaller and then put just a little bit of air in the cuff, and that will be protection.
I have a question.
Sure.
Let's
Let's see. How quick will overinflation cause permanent damage? That's a good question. It depends on the FiO2 that was in there, number one, but once the blood flow stops, I would imagine within 10 to 15 minutes, you're going to start to get cellular injury. I'm not quite positive about cellular death. It's going to be a little bit longer than longer than the brain. But on the other side, I don't want to be the guy to find that out. So I do make it a point never to overinflate a cuff. I have not seen, fortunately, anybody who's ever suffered from tracheal stenosis after a field intubation, because most of the time when they've been intubated in the field, their transport time is less than 15 minutes to the hospital. So I've never seen any tracheal injuries from that. So, but I don't want to put an exact time on it to say you have this long. On the other side is, and we'll talk about tube holders in a little bit, but use a tube holder to hold the tube in place, not a high pressure in the cuff. And again, we prefer cuff tubes, especially if someone's got a full stomach or they're at aspiration risk, because it will protect from passive aspiration within the larynx. Adults over 14. Your average adult female is a 6'5" to a 7'5" tube, whereas the average adult male is a 7'5" to an 8'5" tube. Males have larger larynxes and longer tracheas than females. That said, I like simplicity. What this tells me is everyone will take a 7'5" ET tube, male or female, once they're over 14. Why work hard? Work smart. So that's what I do. If I have a purpose, I'll stick in larger tubes. That's more hospital related. You need a stylet. Stylets make it easier. These are stylets for endotracheal tubes. When you use a video laryngoscope, there's a stylet specific to that model that's preformed in shape. These are not rigid stylets, they're pliable. You'll stick it in the tube. You'll need a 10 cc syringe. Once the tube's been styleted, you're going to want to turn it into a hockey stick configuration. The goal is to come in from the side and then you can just flip it through the cords. And then you're going to want to have a commercial device. In the hospital, in the operating room, we use tape because tape's cheap. In the field and outside the operating room, you would want to use a commercial device to hold the tube. Usually these devices have bite blocks built in, so the person can't bite the tube. Biting an ET tube while you're trying to breathe creates negative inspiratory pressure, pulmonary edema. Very bad for you. It only takes one breath to create it. And that's a problem. In the hospital, these are field ones. In the hospital, we usually use tube holders that have a little bit of tegaderm on it, which protects the cheeks because the patient's going to be intubated for a while. You need to prove the tube is in the right hole. That's done with capnography. You have disposable or portable ones, work by paper, such as an easy cap. They detect CO2. If it turns yellow, carbon dioxide's present. Purple, no carbon dioxide present. When you start ventilating, you'll see the paper for at least a half hour go yellow, purple with each breath. Lets you know the tube's in the right place. This is just pH paper, but it works. There's only one place CO2 comes from, and that's your trachea. That's it. Esophageal intubations, if you swallowed air, you might get 4 breaths. After that, there'll be no more yellow. It washes out. Or in the ambulance, you can use the life packs. They have capnography capability. Now, we're talking about intubation. Patients with impending respiratory failure or anybody with a gag reflex. We need to use drugs to help get the tube in because I don't want to get bit, you don't want to get bit, and we want to take over their airway. So drugs. There's 2 categories of drugs we use. We use amnestic drugs. That way they don't see it coming or remember the event. And we use muscle relaxants. That way we don't get bit. And we're going to talk about each of these. Etomidate. It's an ultra short acting hypnotic. It's used in the operating room. It's short acting. It's not barbiturate. It does not have analgesic properties. It does have sedative and anxiolytic. Very brief amnestic, only for the first couple minutes. It can be used in an anticonvulsant. It works by binding the GABA receptors. Only comes in one size. It's used to pre-sedate responsive patients prior to admission of a muscle paralytic because it's kind of cruel to paralyze somebody because when they're paralyzed, they're still awake and aware. This makes them so they fall asleep. When do we not use it? If they're allergic to it. And that's for any drug. We never give anything to anyone who's allergic. It can't be used in a patient with adrenal insufficiency or Addison's disease, also known as hypocortisolism. How do we know that? Well, hopefully they're wearing a medical alert bracelet. If not, all right, you're on your own. Patient, that is. They get it. Side effects, respiratory depression. Well, of course. It could cause them to stop breathing. Yep, fall asleep, decreased level of consciousness. It can cause hypotension. Less so than a couple others, but it still causes it. It will cause an involuntary myoclonus, which is twitching of the muscles, which is pretty cool to watch. It will cause adrenal suppression, which is not always the best thing for someone who's being stressed. because we like our stress hormones. Its dose is 0.15 to 0.3 milligrams per kilogram IV or IO. We're in your pre-oxygenation period, and it's given over 30 seconds. Lower dose ranges for hypotensive patients. In the Maryland protocols, you're allowed to repeat it, 0.15 mg per kg every 15 minutes if the patient is bucking or not tolerating the tube. I'll offer something later on to that alternative. Important points, always have airway equipment available, lower ranges in the elderly or the acutely intoxicated, or those who are hypotensive. And you need to continuously monitor their pulse ox. You're going to have to breathe for these people. All right, remember myoclonic movements are common. It's not seizures, and it's not fasciculations, which we'll talk about when we get succinylcholine. This drug is potentiated by narcotics. I didn't do that. Gremlins. It's potentiated by narcotics and alcohol. Etomidate only comes in one concentration, 20 milligrams in a 10 ml vial. I've never seen it anywhere else. So when you draw it into a 10 cc syringe, that gives you 2 milligrams per ml. Next drug, ketamine, also known as Ketalar, another short-acting hypnotic. It's given intravenously. It's used in anesthesia. It's a short-acting non-barbiturate. It offers sedative, anxiolytic properties. It works by enhancing the NMDA and HCN receptors. NMDA, if you really want to know, is N-methyl deaspirate receptors, and the HCN is a hyperpolarization activated cyclic nucleotide gated potassium channel. How's that for being a geek? All right. Ketamine comes in a lot of concentrations. I know in Baltimore County, we can have any of them. It just depends on what's available. Ketamine's been on national shortage for at least 2 years now. We get what we can. I think we're currently using 50 milligrams per ml, but I could be wrong. That's what we're using at the hospital. Pay attention to your concentrations. It's indicated as a sedative for responsive patients who are about to be medically paralyzed for rapid sequence intubation. And it can be used as a sedative for patients who are already intubated. Don't use it if they're allergic to it. You have to use it in caution in patients with head injuries because it raises your intracranial pressure. And you use it in patients with caution and high blood pressure because it will also raise your blood pressure. Side effects, respiratory depression or respiratory arrest. Of course, it will decrease your level of consciousness. It too can cause an involuntary myoclonus or movement, not as much as etomidate. Interestingly, ketamine causes people to salivate like crazy. They salivate a lot, so much that the suction will be going. Otherwise, they run the risk of passive aspiration. In the hospital, we'll give them other drugs as an antisalicog or get rid of their secretions. And another side effect of ketamine is unpleasant dreams or delirium. I honestly have no idea why somebody would abuse this drug because of the nightmares, but people do. We avoid the nightmares in the hospital because we give a benzo with it. Important points, myoclonic movements can be common, and don't confuse again with seizures. Don't tell the hospital they seized just as I gave it. They didn't seize. Potentiated by alcohol and narcotics, and they increase secretions. You'll start to see it pouring out their mouth as they're just lying there. If they're not pre-treated with a benzo, they will have emergence delirium, which can be fun to watch, but I don't recommend it. It can be given IV. It can also be given IM. The IM dose is anywhere from 4 to 13 milligrams per kilogram. Most people are going to do either 5 or 10, depending on how violent they are. This is a controlled substance, DEA category 3, so it must be accounted for. Normal dose, rapid sequence intubation, 2 milligrams per kilogram. Sedation, 2 milligrams per kilogram. You can repeat it once. After that, you can give it 1 milligram per kilogram every 10 minutes as necessary for bucking patients or moving patients for Maryland protocols. If you wanted to give it more because for some unknown reason you had a very long transport time, consult, I'm sure they would say yes. Again, it comes in multiple sizes, 200 milligrams per 20 mLs, 500 milligrams per 10 mLs, or 1,000 milligrams in 10 mLs. So 20 mg per cc, 50 mg per cc, and 100. You got to pay attention to what you have, read the label, know your drugs. Midazolam, also known as Versed, short-acting, benzo, very short-acting, and water-soluble. This replaced Valium in the medic units in the field. Works well, doesn't burn. Affects the GABA receptors. It offers sedative, anxiolytic, amnestic, and anticonvulsive properties. I can break a seizure with Versed pretty quick. It is a true amnestic. I can give it to you. I can talk to you for the next 20 minutes. Then about 10 minutes later, walk away, come back and say, how you doing? And you'll have no memories of anything. It's a true amnestic, one of the very few that are true. Comes in multiple concentrations. You have to pay attention to what you have. In Baltimore County, we've carried both. Read your labels. Do not use it in pregnant patients. I had somebody ask me earlier, well, why? What's the problem? It can cause fetal abnormality. That said, that's risk of fetal abnormality occurs in the first trimester. If you have someone who's seasoned in the third trimester, season is very bad for the baby. You can break that seizure with midazolam, and your chances of fetal abnormality at that point are pretty low from the midazolam. If they have it, they probably already had it, and that might be one of the reasons they're seasoned. Do not use it in patients with glaucoma because it can lead to blindness. Don't use it on anyone who's sensitive to benzo drugs. I'm allergic to Valium. Don't give them Versed. Side effects, respiratory depression or arrest. If they take an alcohol and you give them Versed, they'll stop breathing. It can decrease level of consciousness. That's okay. I'm fine with it. And I'm fine with the respiratory depression because we're going to intubate them. Rapid sequence intubation. The dose is 1 to 2 milligrams IV. This is federal protocols, not the Maryland protocols. I'll do you the Maryland in a minute. Some Park Police people here, I don't want them to confuse this. Status epilepticus, 2 to 5 milligrams IV or 5 to 10 milligrams IM, and for cardioversion, 0.5 to 1 milligram IV. Maryland protocol is a little bit different. 0.1 per kg up to 5 milligrams while maintaining the blood pressure over 90. Midazolam really doesn't drop blood pressure. So, and after 2 milligrams, you do have you'll reach your goal of amnesia, but follow your protocols. For our RSI, for a pediatric patient, 0.05 mg per kg up to 5 milligrams. Interestingly, children require more midazolam for effect than adults. And you want to maintain their blood pressure over 60. Midazolam for children for RSI, epilepticus, or cardioversion, 0.2 mg per kg up to 5, or 0.3 mg per kg IM up to 10. Again, important points. Resuscitative equipment must be immediately available. Lower doses in the elderly, acutely intoxicated, hypotensive patients. Continuous pulse ox monitoring is required. Comes in multiple flavors. You should remember there's a danger of hypoventilation, especially in the elderly of COPD, but we're going to be breathing for them anyhow. Potentiated by narcotics. This too is controlled by the DEA. It's a category 4 drug. Lots of combinations it's available in, lots of concentrations. Be very careful with it. At the hospital, we were having problems. I basically standardized it and dropped all the concentrated. All I have is 1 milligram per ml and no more drug errors. Next up, we're going to talk about the other category, paralytics. Succinylcholine, also known as amectin or quilacin. It's a short-acting skeletal muscle relaxant. It works by depolarizing the neuromuscular junction at the postcholinergic receptors on the motor end plates. When you administer it, it will cause every muscle in your body to contract all within 30 seconds. And then it will stay bound to that receptor and keep it that way for another 3 minutes. This, of all the muscle relaxants on the market today, this is the fastest onset. Its onset's within 30 to 45 seconds. No other muscle relaxant goes that fast. All the rest of them take at least 45 seconds, if not longer, to a minute plus. We use it to facilitate intubation. You can't use it if somebody has malignant hypothermia. You can't use it if they have skeletal muscle myopathies. What are skeletal muscle myopathies? Myasthenia gravis is an example. Anybody who has a paralysis of muscles for any reason. Do not use it for people who said they're allergic to it, as in any other drugs. You cannot use it for patients in renal failure because succinylcholine raises the serum potassium, at least 1 milliequivalent. So if your serum potassium hits 6, you get to experience asystole. We do not use this in renal failure patients ever in the field. Other contraindications, burn injuries. Once somebody's received a burn injury, the initial burn, you can do it. 8 hours after that burn injury, they upregulate the receptors, you can no longer use succinylcholine. Do not use it for multi-trauma patients after the first, again, 8 hours. Anybody who's a degeneration injury or epimotor neuron injuries, certain types of paralysis. Never on a paraplegic or quadriplegic. It will cause a hyperkalemic cardiac arrest, and it's a very hard resuscitation at that point. Side effects, in a very small percentage of the population, you'll get prolonged paralysis. Instead of it lasting 3 to 5 minutes, it'll last 8 hours. I've seen that in my career. It happens about once every 10 years. I've seen 3 of these now. The fasciculations can be very dramatic because you're contracting every one of your muscles vigorously. And that can increase trauma to a fracture. Side effects, if you've eaten, you might aspirate. We'll talk about ways to try and protect that a little bit later. You can get cardiac dysrhythmias. Dosage, 1 to 1.5 mg per kg with an onset in 30 seconds most of the time. You can give this IM. Generally 100 to 150 milligrams IM is what they're going to get, 4 to 5 milligrams per kilogram. Instead of a 30-second onset, it'll have an onset in 2 minutes. Interestingly, if you give this to somebody IM, they will know immediately and they will rapidly go into a sheer state of panic just before they collapse. Generally, it wears off within 5 minutes. Very rare does it go over that. You cannot give a maintenance dose. You cannot repeat it. What you need to remember, when you medically paralyze somebody with succinylcholine, they will be cognitive and aware of everything. They hear everything you say, they feel everything you do if you did not give them an induction drug. It offers no analgesia. It will increase the intracranial pressure, the pressure in your head. It will increase your intraocular pressure, and it will increase your intragastric pressure. So you're saying, well, why do we use this for head injuries? Because it raises the ICP. Well, if they're not breathing, hypoxia will raise your ICP even more. So it's the lesser of two evils. And then we can hyperventilate them and try and lower their ICP. Intraocular pressure, airway, breathing, circulation deficit. Better to be alive and blind than dead. So for eye injuries, and then you might lose one. Maybe not, most of the time not. Again, you can get prolonged muscular paralysis in predisposed individuals. Those individuals, their medical alert would say either succinylcholine allergy or pseudocholinary deficient. The fasciculations can be rather vigorous. Again, oxygenation always takes precedence over ICP, IGP, and IOP, and you need continuous pulse ox monitoring. Remember, once you give it, that person is dependent on you to breathe. They cannot oxygenate or ventilate themselves. You have to do it for them, whether with an oxygen bag and a mask or an ET tube or an LMA or something. But if you need a breath, they need a breath. So keep that in the back of your mind. You take a breath, they get a breath. And then only one dose, one and done. They do not get a second dose afterwards. You get free choline, which causes a phase 2 block, which causes bradycardia, followed by asystole. Comes in one concentration. It comes as 10 ml vial with 20 milligrams per ml. Next drug, vecuronium, also known as Norcuron. It's an intermediate acting muscle relaxant. It works by blocking that same postcholinergic receptor without causing it to fasciculate. It's just a big molecule. It binds to it, but prevents anything, the acetylcholine from binding to it. Therefore, you get flaccid paralysis. It's again used for intubation, and it can also be used to maintain skeletal muscle paralysis. So if you intubate somebody with sucks, and then the sucks wears off and they start moving and you want them to hold still, give them VEC. And they'll hold still for a good half hour. Don't use it if they're hypersensitive to it or allergic. I've never seen in 30 years anyone allergic to vecuronium. The molecule is a steroid, so that decreases it even more. Prolonged paralysis or weakness if given over a long period of time. In the ambulance, it's not your issue, and it'll wear off, so don't worry about it. Its dose, 0.08 to 0.12 mg per kg or 0.1 mg per kg. Maintenance dose, just give them 10 milligrams, and it'll last 20 to 30 minutes, unless the patient is an alcoholic, and then it'll wear off in 10. That's how we find closet alcoholics in the operating room. Our muscle relaxants wear off. It's not affected by age, and for some reason, women seem to be more sensitive to it. The drug is devoid of significant cardiac effects. I don't know of any. You can give it to patients with renal failure or hepatic failure. Comes as a 10 milligram white powder, which means it stores well. We can reconstitute it. And it means we can make it any concentration we want. I usually put it in a 5 cc syringe and give it all. Finally, for drugs, we have our resuscitative drugs that I'm not going to talk about. Everyone knows what they are, and everyone knows how to use them. That said, we want to take a break for questions, then we can take a break now. We'll take a 10-minute break, 5 to 10 minutes. We'll make it in the middle, an 8-minute break. What are the questions? It's called a muscle. Why is succinylcholine called a muscle relaxant? It causes all the muscles to contract. Because after they all contract, you have flaccid paralysis. So the contraction will last 15 seconds, and then the paralysis lasts for anywhere from 3 to 5 minutes. And generally, you can get somebody intubated in less than 60 seconds. And that's all you need. That's why it's called a muscle relaxant. I don't know, interestingly, the succinylcholine was invented today. I don't know if the FDA would approve it. But since it was one of the first, there you go. All right, now's a good time for a break. Yeah. Oh, there it is. It did work. Very cool. Well, I want to welcome everyone back. We're going to go a little more deeper now into airway anatomy and as we get towards RSI and beyond. Wait, I don't remember which button. This didn't work. Hold on. Did I just do something? Nope. There. All right, it worked. All right, so we're going to talk about airway anatomy. What you see before you is a little schematic of the human through a cross section. At the top, we have the nasal pharynx. We see the word tongue, that's your mouth. Teeth in the front and the back is the oral pharynx. Beneath that, you have the epiglottis, and that little U space in between is the vallecula. In front, you see vocal cords, and behind, which is on white, is the esophagus. And this is the simple version. Surrounding your pharynx is layers of muscle. I find it interesting. People are afraid during laryngoscopy to push or lift really hard because they're afraid they're going to break something. As long as you're not touching the teeth, you won't break a tooth. You can literally suspend the head off the ground of a laryngoscope as long as it's firmly seated on the tongue. And they do that in the operating room sometimes. It's called a suspension laryngoscopy. You're not going to break anything. You might dislocate the mandible. We'll pop it back in, but you're not going to break any bones because the only bones involved is the mandible and the hyoid bone. And the hyoid bone is a sesamoid bone. It floats. Everything else is either cartilage or muscle. So don't be afraid. Again, when you look down, you're going to see the epiglottis at the top, the vocal cords along the side, and then you have this little circle of arytenoid cartilage. And then down the middle, you'll see what looks like a long tube with arches over top. That is your trachea. And those are called tracheal rings. On the outside, in the front, if you look to the left on the anterior view, is what would be just under the skin of your larynx, and you're going to see thyroid cartilage, cricoid cartilage with the trachea underneath when we talk about cricothyroidotomy later. You're going to notice that the cricothyroid ligament is located between the thyroid cartilage and the cricoid ring. That's the area you're going to want. You don't want to go through the trachea. From behind it, you can see again the big epiglottis and the larynx from behind. So we need to talk about physical exam. Physical exam predicts ease of intubation. An airway exam is done on everybody to decide if they can do a successful laryngoscopy. This is based off of several things. Now, that all said, and everything we've talked about, I need to bring this up. Again, I said there's no contraindication to a patent airway. On the other side, you need to oxygenate and ventilate a patient. If you can successfully bag ventilate a patient with good chest rise and CO2, continuous CO2, up and down on the waveform, you're oxygenating and ventilating that patient, and you're delivering oxygen into the brain, into the heart, and the rest of the organs. And that's okay. If you have a hard time doing that, and what we find in the hospital when we bring people in from the field is people don't realize how hard that can be sometimes, especially when you've been doing it for 15, 20 minutes. But if you can do that, that's good. And there's nothing wrong with that. And they don't have to be intubated, especially if you have good airway control, there's not a lot of secretions, and you're maintaining your patient. But we need to talk about physical exam or airway exams to predict ease of intubation. So what are the factors involved to predict it? Size of tongue versus the pharynx, atlanto-occipital joint extension, the anterior mandibular joint space, dentition or teeth get in the way, presence or absence of tonsils, and presence or absence of maxillary tori. Teeth, tonsils, and tori. We're going to talk about all of them. And most of you have no idea what a tori is, but I'm going to show you a picture. All right, the first thing, the tongue versus the pharynx. This is called Mallampati classifications. You don't need to know that. You just need to know class 1, 2, 3, 4, and we're going to define each of these. And this is looking in the oral cavity. If you open your mouth and you can see the uvula, which is that little thing hanging in the back, if you're on the far side comics, it's the final exam on the medical school questions. Okay. It's a cool cartoon. All right. But if you can see the uvula and you see all the way back, that's a class 1 airway. If the tip of the uvula touches the tongue and you can still see back, it's class 2. If you can kind of see back but not see the uvula, class 3. If you don't see anything, class 4. Class 1 and 2 are easy intubations. Class 3, you're going to work at it, but you should be able to do it. In class 4, very difficult laryngoscopies. The way protocols are written for elective intubations, class 1 and class 2 allow for laryngoscopies. Class 3 and class 4, no. But that was before the advent of glide scopes, and glide scopes have changed that. Glide scopes will allow you to do class 1, 2, and 3 intubations with ease. Class 4, you'll work at. So to put it a little more in perspective, Mallampati 1, top left, Mallampati 2, top right, Mallampati 3, bottom left, and a Mallampati 4. And again, what we just talked about. Mallampati 1, you see the entire glottis. Mallampati 2, you'll see the posterior commissure, which is the bottom. Mallampati 3, the tip of the epiglottis, and the Mallampati 4, you see tongue. So grade 1, grade 2, grade 3, grade 4. If you can see it, you can hit it because these are straight shots. Now for grade 3, there's lots of tricks to get it. Basically, you know where it's at, you put a hook on it, and your tube will slide in. Grade 4 is pure guesswork. To put it into pictures that look real, grade 1 is A, grade 2 is B, grade 3. I know the vocal cords are on the other side of that. With a good curve on the ET tube, I'll get it. And that grade 4 view, I'm not sure where it's at. And chances are my tube will slide above the epiglottis just as it could below it. It's a difficult intubation. So Mallampati classification predicts success. Class 1, easy. Class 4, hard. If you can see it, you can hit it. If you can't see it, then it becomes a matter of skill and guesswork. And the more you do, the better you get. All right, atlanto-occipital joint extension. What is this? This is how much you can straighten your neck and airway out. Again, back to your sniff position. A successful exposure of the glottic opening via direct laryngoscopy requires an alignment, right, of the oral, pharyngeal, and laryngeal axis. And this is the sniff position, and we'll give you your best view with a laryngoscope. Not the same for a glide scope or a video laryngoscope, but for a laryngoscope, this is how you get your best view. But what you have to remember is for trauma patients, you can't do this because in trauma patients, the C-spine needs to be neutral and we don't like to torque the neck or extend it in trauma patients. Greater than 2/3 decrease in AO joint extension on a normal axis is associated with a greater grade 3 or 4 view. More you can increase your extension, the better your view. It's a straighter shot. Anterior mandibular joint space. This is the distance from the tip of the mentum, which is your chin, to the notch in the thyroid cartilage. The patient should maximally extend the mandible via flexion. So go to forward, stick your hand here. 4 finger breaths is the equivalent of 6 centimeters. Easy intubation. So a thyroid mental distance less than 6 centimeters is associated with more of an acute angle of the larynx and a difficult intubation. Where it's greater than 6, an easy intubation. Thyroid mental distance. And from the top down, it gets progressively harder, you see. Teeth get in the way. They decrease the opening, they limit manipulation. Edentulous patients, we love them. Maximum degree of laryngoscope manipulation. And by the way, dental injuries by laryngoscope are compensational events. The average settlement is $5,000 per tooth, just so you know. Document teeth exams in your additional narrative. Bad teeth before and never get better with intubation. Yet for some reason, people find that if they think you're going to buy them a new set of teeth, all of a sudden you did it. Number 8 is missing. This picture here, we see this a lot. I point this out because you do not want to touch these with your gloves. They're sharp as razor blades. They'll cut through gloves. They'll also cut the cuffs when ET tubes. And they all carry bacteria, and you don't want these bacteria in your fingers. You're going to have IV antibiotics if you do that. Don't get bit, especially by something like that. Again, we always do and document pre-dental exams and pre-existing dental abnormalities so we don't have to write big checks later. Loose teeth or aspiration risks, dental prosthetics, partial plates, dentures need to be removed. Otherwise, they flip in your way during laryngoscopy. Missing teeth or fractured teeth need to be documented. You'll notice on the right, tooth number 9 is broken in half. That occurred to somebody after a laryngoscopy, but if you pay attention to that tooth, at the very base of it, you see a cavity. That was a dead tooth before, so no wonder it crumbled. All right. Trauma can be associated with injuries to teeth, maxillary mandibles. Anything that decreases the structure of the mandible will decrease the structure or integrity of laryngoscopy success. Bleeding will obstruct the view. You see this with broken jaws. See it a lot. Laryngoscopes don't do well with broken jaws, but video laryngoscopes do. Tonsils, present or absent. Absent tonsils, big visual field. Absent tonsils, not so much. A lot of kids come to the OR for a tonsillectomy. Hypertrophic tonsils get in the way. There's a child with tonsillitis coming in for a tonsillectomy. The uvula is the little thing at the top, and the 2 things on the side are hypertrophic tonsils. They've obviously been on antibiotics because there's not pus coming from them. That said, how do we get the tube around it? Well, actually, you stick the laryngoscope in sideways and then try and gently part it like a curtain so it won't bleed. Tori, maxillary tori, is a hard mass on the upper palate It has many appearances. It's congenital. You're born with it. People who have it don't realize it's abnormal. The incidence in the United States is 20 to 30%, more common in women than men. Large tori get in the way of your laryngoscope and they decrease the area to manipulate it. This is an extreme example. Most of them will look like just one of those bumps, but I've seen this, obviously. Now let's talk about indications for airway intubation. We intubate to provide a patent airway because patients can't effectively be ventilated with a mask for whatever reason, usually a large tongue. Number one cause of airway obstruction is tongue. To hyperventilate head-injured patients who are unconscious, unresponsive, to prevent aspiration risks for patients who don't have a gag reflex and can't protect their airway, usually Glasgow is less than 8. Anybody with an open chest wound, because you need a negative inspiratory pressure to breathe in. If you have a hole in your chest, your lungs, when you go to inhale, will preferentially go through the hole because it will have less resistance than over your tongue. Anybody with symptomatic smoke inhalation needs to be intubated. Anybody with heat injuries needs to be early intubated because they're going to get edema. Anybody with airway trauma, anybody with fulminant pulmonary edema, stage 3 or 4 heart failure. Anybody with impending respiratory failure, or cardiac arrest. They all need to be intubated. That said, let's talk about rapid sequence intubation. It's a subcategory of this. Rapid sequence intubation, or RSI, it's done on anybody who has a full stomach, which is most of our EMS patients. Any patient needs to be intubated who has had something to eat or drink within the last 8 hours, who's not unconscious and not unresponsive. Did I say that right? Yes. If you're unconscious or unresponsive and you don't have a gag reflex, you don't need an RSI. You can have a normal laryngoscopy. Contraindicated, anybody with a difficult airway based off a physical exam, Mallampati 3s and 4s for a laryngoscope, for example. Anybody in cardiac arrest, they don't need it. No gag reflex, they don't need it. Anybody with an allergy to any of the meds we use, because you can't do it in an ambulance. They have other things in the hospital they can do. You need to set up for it. This requires at least 2 providers, if not 3, especially if there's a concern for C-spine injuries, say trauma. You need full monitor, an EKG, pulse ox, and blood pressure. You need working suction at the head of the bed. You don't want to have to look for it because when people start vomiting, it happens fast and furious. You want to pre-oxygenate the patient either by somebody bagging them with an ambo bag or with a non-rebreather mask. You need an IV line or an IO line to establish free-flowing intravenous fluid so you can give medications through such. You want a stylated ET tube of the predicted side and a second tube one size below readily available at the head of the bed. All your equipment is going to be at the head of the bed with the patient, so you don't have to turn around. Your laryngoscope should have been prepared and tested before you ever got in your rig or your unit that day, and you want a second blade of a higher size or bigger just in case. You want to sedate the patient. I prefer in the field midazolam because it doesn't drop the blood pressure. If they can spontaneously breathe, that's fine. I'm going to give the appropriate dose per protocol. For park police, they're going to get 2 milligrams. Let them work. That will create the amnestic. And I'm going to have a little bit of gentle pressure on the neck. This is called a Salix remover. And this displaces cartilage down, and I'll show you a picture in a minute. Now, anybody with a cervical injury, you want to make sure there's no cervical movement. So you're going to kind of support the neck with your other hand. And then you're going to press gently down. And what this does is will protect the patient from passive regurgitation of gastric contents when they get medically paralyzed. It will not protect from active regurgitation. And if you try and hold it really tight for active regurgitation, you can tear the esophagus, and that would be catastrophic. Then the patient gets an appropriate dose of succinylcholine, milligram per kilogram. Generally, for rapid sequence, we don't ventilate the patient. They've been pre-oxygenated, so we've replaced the air in their alveoli from 20% to 80 or 90%. That gives them a reservoir for them to draw on from 4 minutes, now probably about 6. Watch them fasciculate. Protect them from any further injuries if they do, but it's not going to be that vigorous. And then you start the procedure. As soon as the fasciculation stops, you'll perform a laryngoscopy either with a video laryngoscope or a manual laryngoscope. If you don't see any fasciculations within 40 seconds, just start the laryngoscopy. The suck's already worked. If they stop fasciculating after 25 seconds, you can start that. That's a Mac blade. It's slid into the vallecula. You'll lift forward, brings the epiglottis up, and it gives you a view. At that point, intubate the patient. So if you're looking down, you'll see the cords. If you can see it, you can hit it. Slide the tube in, you'll come in from the side. Cricoid pressure supplement, especially for video laryngoscopes, because if you can see it, you can hit it. There's a maneuver called burp. The British named it, not us. So which stands for backwards, upwards, right side pressure. And if you're looking at that view, you can manipulate by pushing a little bit down and a little bit to the right and turn that grade 3 view into a lovely grade 1 view. And it's easy. If you come to the hospital, we'll practice that in the OR. So turn your grade 3 to a 1 and then intubate. If for some reason the intubate's not successful, then reevaluate as to why. Maintain your cricoid pressure. The definition of insanity is doing the same thing over and expecting a different result. So that's not going to happen because you're going to change something. Why couldn't you get it? Was the laryngoscope blade too short? Was the tube too big? What do? Do something different and then make a second attempt. If the second attempt is successful, great. Confirm tube placement with capnography, auscultation, and then you'll secure your tube. When we auscultate in the mid-axillary line, not the mid-clavicular line, because there's too much crossover in the mid-clavicular. Capnography tells you the tube is in the trachea, but it doesn't tell you how deep. Auscultation in the mid-axillary line will tell you if it's in the right side or the left side or both. As long as you stop right after the cuff passes, you'll be fine. If it's successful and you have capnography, you've demonstrated it, you're going to secure your tube. Use tape, whatever your service uses, a commercial device. Commercial devices are great in the field, especially moving ambulances. Once it's secured, and I recommend securing it to the upper lip. The one on the right is correct. The one on the left is not. That gives stability, and then you're done. When you do secure the tube, make sure you don't have the upper lip trapped between the teeth in the tube. That way there's not pressure on the lip. At this point, I would put a cervical collar on just to give stabilization and make it easier for ventilation. If your protocols allow, federal ones do, at this point, medically paralyze the patient. That way, when the succinylcholine wears off, they can't buck, they can't cough, they can't pull the tube out. For Maryland protocols, they would rather you use either etomidate or ketamine. That's fine. In the federal, it's vecuronium. If the laryngoscopy is unsuccessful, on the second attempt, gently ventilate with 100% oxygen until the patient either starts breathing again on their own, or think about a different adjutant. What are those adjutants? Think about an LMA, laryngeal mask airway. If you don't have that or that doesn't work, think about a surgical airway. So LMAs are simple. My personal belief is this can be an EMT skill. I mean, we allowed EOAs in the 80s and combi tubes in the 90s. I don't see why. Let's give it a year or two. We'll see what happens. Take a lubricated LMA of the appropriate size. There's a table for them. We can say the average adult male gets a 5, the average adult female gets a 4, and then you're going to slide it in. It's like placing an oral airway almost. Just make sure it's well lubed, slide it down over the tongue. You'll feel it seat, at which point, try and ventilate. Tube chart for LMAs, size 1 to 5, from neonates to adults. This is what it looks like seated. That's a laryngeal mask airway working. If CO2 is noted on the capnography, you're good. Just keep form. If there's no CO2, repeat the attempt with a smaller size LMA. Especially if you started with a 4 or 5, go down one size. If there's a leak door ventilation,
You felt the seat, you get in CO2, but you hear it with every breath leaking around the side, and you'll know what it is, then switch to a larger one. If the LMA doesn't work, they're paralyzed, you can't ventilate, then they become a candidate for a cricothyrotomy. I can't ask questions here because it's all virtual. This is a child who got an emergency cric. If you look at the child, you'll notice they have burn injuries, which is very sad. Now would be a good time for questions if you want to write something here. If not, we'll move forward. All right, so let's talk about cricothyrotomy. I did one of these a couple months ago. Emergency cricothyrotomy catheters are designed to establish emergency airway access when endotracheal intubation cannot be established. There's a company called Melcor that makes catheters kits. They're basically surgical trays for emergency airways. It's designed for a percutaneous entry technique through the cricothyroid membrane, utilizing something called the Seldinger technique and a 6 mm internal diameter airway catheter. It looks like an ET tube, but it's much simpler. And then we're going to go over this because you'll guide it in first. You place a wire, then a needle, or a wire via needle, wire out, dilator in, catheter in, everything out but the catheter, we're done. So what do we need? We need a catheter set for crics. We need sterile gloves, personal protective devices, because this can get a little bloody, eye protection for sure, local anesthesia of the person's cognitive. You need a prep solution, alcohol, chloroprep, or betadine. And then your cric tray. You'll notice it contains a syringe, a scalpel, an introducer needle, which is basically a large IV catheter. It has a dilator, and then below it, at the bottom, is 2 views of the airway catheter.
It was just a quick question. Did the child make it?
Did that child? Yes, that was post. That was like 24 hours later. All right. Patients with airway injuries are at high risk for cervical spinal injuries. Remember that. So always have C-spine control. And again, aseptic technique, local anesthesia if necessary. If they're moving, give them local. If they're unconscious, unresponsive, you can skip it. Clean and prep the neck. Get all the dirt off. This is a surgical procedure. This is a big deal. You don't want to introduce dirt into the airway. Clean the neck. Assemble the catheter. And then you're going to take a syringe and draw 3 cc's of IV fluid into it, and then attach the 18-gauge IV catheter to it. So this is what an assembled airway catheter looks like. You have a large dilator with an airway catheter located in the middle. Identify the cricoid membrane on the neck. It's just below the Adam's apple. A classic mistake is above. If you stick it above the laryngeal cartridge or that thyroid cartilage, you're going to come out the back of the tongue. Very embarrassing. I've seen this before. No style points. Below the cricoid ring, it's going to go through the trachea. It's a lot harder to work. The sweet spot is the cricothyroid membrane. So thyroid cartilage, cricoid cartilage, the spot in between. And this is not something you do without practice on mannequins and dead animals. Palpate the cricothyroid membrane. Small amount of pressure to stabilize it. Use the scalpel, make a small vertical midline incision, not horizontal. Horizontal increases the risk of cutting blood vessels. Vertical. So you're going to stab the neck just above. Make a little hole. Then you're going to take an 18-gauge IV catheter attached to a syringe with usually saline or LR in it and start pushing it through the hole. And draw them back on your syringe as you do it until you get free air or bubble in within the solution. Because there's only one place air comes from, and it's in the trachea, because you're too high up to be in the chest. You have air return, that means the tip of the catheter is in. This is the easiest IV in the world to do, because it's huge. You stick the catheter in, you're going to remove your needle, leaving the catheter behind. So catheter in, needle behind, needle out. Once that's in, you're going to take the wire out of the tray and you're going to insert it through the catheter. Wire in, Make sure that catheter is pointing down while you do it so it doesn't pop out the back of their throat. And at that point, you're going to want to remove the catheter. Don't let go of the wire. Don't lose the wire, please. So hand on the wire, catheter out, and then keep a hand on the wire. At this point, you can place the dilator over that catheter and slide it in. What I would do is I would take that scalpel blade and slide it down the wire to make the hole just a little bit bigger. Makes it a little simpler. Then you're going to take the catheter, airway catheter with the dilator attached, and you're going to push it on through. This catheter will slide over the wire. The tip, I can't show people here. The tip is hollow. Wire goes in, it'll pop out the back of it. You're going to slide it in. You're going to advance it through. You're going to feel a pop as it enters. If you can't push it through, take the scalpel blade and along it and make the hole just a little bit bigger. And then with firm pressure, slide it on in, just like that. Once the catheter is in, you're going to remove the wire and the dilator as a unit and leave the catheter behind. And this is what you got. And this works. I did this a couple months ago to somebody who had lockjaw, who was vomiting, and it was not a pretty picture, but it worked. It went in. You're going to secure the catheter in place with cloth tracheostomy tape that comes in the kit and ventilate through it. Capnography in line. Make sure you have chest movement. You can listen. If not, again, enough trauma that caused this, make sure you have bilateral. There's no way you're going to have a one-sided thing. Think pneumothorax. You might have a second catheter going into the chest for if you're a paramedic. But this is a different model. But this is a person who got an emergency field cric. Once the catheter has, he's actually coming to the operating room to have it removed. Once, that's a 9.0, that was a lot bigger. Once the catheter has been secured, put a cervical collar on for stability. That way you don't accidentally pull it out. Please don't do that. It's not that easy to put right back in. And start ventilating. Once somebody's been intubated, whether a cricoid or an ET tube, they get their stomach decompressed. Everyone gets their stomach decompressed, oral gastric or nasal gastric. If they're intubated, just do an oral gastric tube. They're easy. You've already blocked one hole. There's only one other place it can go, down the esophagus. 18 French for adults, 12 French for kids. What this tube will do is it will relieve gastric distension, which will allow you to ventilate easier, gets the air out. If there's fluid in there or vomit in there, it'll pull a lot of that out. Who gets it? In Maryland protocols, all pediatric patients and any intubated gastric adult patient with gastric detention, because gastric distension will compromise ventilation. Basically, I place this tube in everyone who's been intubated. Just makes it much simpler. You just leave it there. Contraindications, there are some esophageal varices, which you can see in alcoholics. Anybody who's had esophageal or gastric bypass surgery within the last 6 weeks. This is for oral or nasal tubes. For nasal tubes, don't stick it in anyone you expect for a head injury, a skull injury, or has nasal deformity or trauma. At the top of the nasopharynx, something called the cribriform plate. It's a very thin piece of bone. Cranial nerve 1 goes through it, which allows you to your sense of smell. There's too many x-rays out there of NG tubes inside people's brains from going through the cribriform plate. Don't be that person. And then it would also be a pretty bloody mess because they'll bleed. On the other side of the cribriform plate is a dural sinus. Special circumstances, nasal tracheal intubations. Same thing, but through the nose. Most people are doing these now at this point with glide scopes. You stick the glide scope in like you normally would, and then you slide the tube in through the nose, down and around. That's a whole nother lecture. I did the very first nasal intubation in Baltimore County a long time ago before an oral intubation. That generated a lot of paperwork. That was back in the early 90s. It was awesome. Needle decompression thoracostomy, that's done for tension pneumothoraxes. Choking people, direct laryngoscopies,
Use your McGills, pull out foreign bodies. Tracheostomy changes, or people who had tracheostomies that fell out and you can't get it in, they can get intubation, or we can try and reconnect to an end. If the tracheostomy is old, the sooner you can get it in, the better before that hole closes, because it will close very quickly. People who have trachs, such as nursing homes, we can suction the trachs if your jurisdiction allows it. BiPAP, as opposed to CPAP, there's now BiPAP out there. BiPAP is more effective than CPAP. It will assist you better with breathing than CPAP. CPAP, you have to work a little bit harder. Protocols are now being written for BiPAP. And then the latest thing that's starting to see is humidified high flow nasal cannula. We'll see how that goes, but I can see that coming also to the ambulance probably pretty soon. It's there. It's all there. These are interesting times we're in. All of this is good. My other ambulance again, it's really cool. You gotta love this. I have the coolest job in the world. Baltimore County has an SOP 600-24, which is a flow diagram for airway management from beginning to end. It's out there. It's basically, we've gone over a lot of this. I want to thank you all for what you do. I think you are the most awesome people in the world. March 21st, 2022. I got to experience it firsthand. Thank goodness I taught that person well, because he's actually sitting in here listening to this lecture right now and didn't expect this, but he saved my life. I had 36 minutes, was it, of CPR, at least 38. Oh, great. 38 minutes of CPR, 10 defibrillations. I was brought to the hospital on a Lucas. Within 8 minutes, I was in the cath lab and an emergency angioplasty. They put me on ice, and I don't remember the rest of the week. I don't remember that day either. But you guys are amazing. You do wonderful things. I can't say enough good things about you. You saved my life. I wasn't too brain damaged, because here I am giving the lecture now, and I'm still Chief of Anesthesia at Sinai. Any questions? You'll have to read them to me.
Got a couple of comments. Wow, that's amazing. Wow.
Thank you. This is all your fault. You made all these pipe peels suffer tonight because of it.
Get that playing them every day.
I think it's awesome.
The chat is all thanking you and saying you did an excellent job.
I'm hoping that iGels or LMAs will become an EMT skill. We'll see. Nothing happens overnight, but we're definitely making advances.
Just a couple more things. Seems like no questions.
No questions. Well, if there's no questions, make sure if you want, you take the continuing ed in the chat. What is this? I do have a picture. This was one last picture I have. This is what I pulled. This is actually about 3 centimeters by 2.5 centimeters. I pulled it out of the larynx of a kid. Another thing I pulled out. It's a lychee. It's some kind of seed. No, it's a seed. It's a hard nut or seed. It's not a nut. You don't eat them. This kid sucked it in. It was horrifying. It jammed in his larynx. Pull it out. Then he ended up in the ICU for a week with negative inspiratory pressure pulmonary edema. And this is a partial plate somebody wore that I pulled out. Who wears a single tooth partial plate? I don't know.
So there's the one tooth on it.
There's one tooth. And I pulled this out of a guy's larynx. Amazing. So, I don't know, just get a permanent bridge. It makes no sense to me. These are both recent things. So, but that's everything. Again, thank you for spending some time with us tonight. Most people know how to reach me if you have any questions. I am car 606 in Baltimore County. I can be reached through the EMS office. Thank you for coming.